So a couple of housekeeping rules. I just want to always tell you that the restrooms are through that archway to the right if anyone needs them. And when we facilitate sort of a group conversation, one of the most important things are 4 rules, and I'll never remember them all, but one of them is to speak from the heart. So make sure that whatever you're saying, it could be any sort of question that you might have or anything that you want to add to the conversation, but it's okay to just speak from the heart. The second one is to be brief. Other people might have something to say, and often it's much more important to try and be succinct in your speaking. I wish Lawrence was here because he always talks for a long time and he knows this. He always says lovely things, so we don't mind. One of them is to not think about what you're going to say before you say it, so act spontaneously. Just feel free to listen to what other people are saying and then give whatever you'd like to the conversation after. And the 4th rule, I'm coming up late, but if you break it, I'm going to kill you. So no biggie.
It's confidentiality, isn't it? Very good.
No, I mean, that is part of it, of course. You know, just feel free to share what you want to share, but there was another rule, but I can't remember it.
I'll speak spontaneously.
Okay.
Think of it.
Okay, good. Yes, whenever, just blurt it out there whenever it comes up for you. That's what we'd like to hear.
4th rule is be informal, have fun.
Yeah.
Don't be shy. See how many more than throw out there.
Right. I mean, I think that the best part about community conversations is there are no bad questions, and we're all sort of struggling with sometimes the same dilemma, but no one wants to raise their hand and say something about it. So just feel comfortable and free to say that here.
Well, to keep tradition, we typically always go around and introduce ourselves. So I'm Josh Simpson, and like Todd said, I'm Director of Nursing with Hospice, Missoula, and care at home, home-based care for seniors.
John Walker, I teach at Missoula College, and my son died at a hospice facility in Colorado.
John Lang, I moved out here 2.5 years ago to run the YMCA. Steve Alpy, currently retired.
Claire Sherwood, social worker for hospice. Angie, RN for hospice.
Bob, just here to here.
I'm Amy Hetzler, here as a community member with aging parents and needing help navigating the path ahead, and also a representative of Compassion and Choices Montana.
I'm Kurt, I'm just here.
I'm Terry, and I'm a nurse at Hospice in Missoula.
I'm Fran Coover, and I've got 2 family medical emergencies going on, as it turns out, tonight. So if my cell phone tells me it's one of those, I'm going to step out, not because I don't want to be here, but just because these emergencies are ongoing. So.
We're just introducing ourselves.
You're on.
Hello there. My name is Hanson. I'm here. It seemed intriguing, the advertisement I read. And I don't know the terms survivor. I don't know what the definition of survivor is, but I have cancer, so I thought it'd be interesting to come tonight.
Thanks for coming here.
And I'm Todd Dubois. I'm the volunteer coordinator at Hospice in Missoula.
See, you're always back.
And you all know Marika, she's our administrator. So, well, tonight's going to be a little bit different than most community conversations, and not so much at the same time. So it'll be very informal, and it's open for people to talk about. The topic we're going to speak about is navigating the healthcare system with a serious illness, particularly, which is a big problem to a lot of people, because you get diagnosed, or your family members or loved ones get diagnosed with an illness that is seemingly serious. Maybe it's not terminal yet, but then you get lost in this big business that is healthcare, or that has become healthcare. So who do you go to for answers? So we're going to talk about that, and we're also going to talk about palliative care. So how many of you tonight know what palliative care is? Okay. So, and how many of you know that palliative care and hospice care are not the same thing? Okay. So I want you to watch this video first. I also want to let you know and apologize if I'm scattered, since I will be honest with you and just put this together this morning. It's been a busy couple weeks.
You put that together this morning? Whoa. Awesome.
No, but that's a really good explanation in a nutshell about palliative care. So, but the problem with palliative care is that it's so new that it's not really feasible financially yet. We're not quite sure how that's going to happen. So that's something that you guys can help with by talking to people, talking to your doctors about things like that, and your insurance carriers. But we'll get into that in a little bit. I did find an article that was written by Peter Weiss. He's a physician. That talks about 3 ways to deal with serious illness and engage the healthcare system. And I'm going to just read through a couple of key points through this article. If you have any questions or anything throughout, just speak up and let me know. Peter Weiss, he starts by saying that he's deeply conflicted about how we as a society have come to use physicians, medical science, and advanced technology in our lives. Everything has its place in life, but we have given modern medicine, with its focus on chemistry and physics of illness, too prominent of a place. We've forgotten that we are not treating diseases, we are helping people with diseases. This brings to light a story that we just recently had brought up to our attention at Hospice in Missoula by a family who we're not yet seeing, but who we've been helping through his disease process with prostate cancer. He's a fairly young individual, but he's been all over the country trying to get treatment. He's not ready for hospice yet. He's, like I said, he's pretty young. But he doesn't really need palliative care either because he's not having a lot of symptoms. His biggest complaint is that he is tired of being treated like he's a number. There's only 2 people that he's come into contact with in the last years that have actually treated him like a human. A social worker, and then one of the nurses up in a different clinic outside of the state. And that was his question to us was, how can we find somebody around town that'll treat us like us? Because we realize we have prostate cancer, but that's not what we do. Many readers, especially those with lifestyle diseases, can be well and avoid care altogether, if they choose to. But I know that some of you have serious non-lifestyle conditions, for example, cancer or lupus. You may have to rely on medical care, perhaps a lot of it. I want you to be empowered to manage your own care. You can do it. So he goes on to ask you to allow him to make 3 fundamental suggestions. And reading through these suggestions, they're great suggestions. I take a lot from them. The first one is to be in charge. And he talks in here about how somehow us as a society have gotten to the point where it's our physicians, as much as they are, they're very smart, they're educated, but they don't know everything. But more often than not, we expect them to tell us what to do. And we'll do everything that they tell us to do, even if we don't understand what it is they're telling us to do. So he talks about being in charge, and he says, somehow we've developed the idea that physicians know best, that medicine is too complicated for us to understand, and that we must trust the judgment of the experts. Perhaps we've been complicit in this because it is emotionally easier not to bear responsibility for our own decision making. These ideas just aren't true. Your doctor may be an expert on your particular diagnosis and certain treatments, but they can't be an expert on you. Only you really know yourself, your hopes, your fears, and your goals, how your current treatment affects you, how to balance the risks and benefits based on your own values. Your values might not be your physician's values. So how much do you know about what's actually available to you?
About what?
About what is actually available to you. So Dr. Weiss in this article really wants to empower us to take charge of our knowledge. Get online, talk to people, ask the doctor, what are all my options? Continues to talk about ensuring that complex subjects are explained to you in simple terms. So how many times have you gone to a physician's office and you've left not knowing what they've said to you? Because sometimes we forget, and I forget sometimes too, that my knowledge is not universal. So I've been taught how to speak like a nurse, but people don't understand what I'm talking about. So I need to make sure that I'm speaking to them at a level that they understand. That's probably the biggest injustice that we can do as a medical professional to our patients and their families, is to not give them the information that they understand fully. And also to not give them all of their options. How exactly might this treatment benefit me? How might it hurt me? What other alternatives are available to me? What if I do nothing? Dr. Weiss really encourages you to find a doctor, nurse, or other medical professional that can explain it simply to you. If yours can't, then find one that can. Even assuming your physician is an expert, realize that they don't know everything. Most doctors in America are educated and trained in Western tradition of medicine. How does your doctor know what comes from other traditions? Are these other traditions right for you? Yet your best answers might come from traditions outside of Western medicine. Will your physician be able to answer these questions for you? If not, can you find somebody that can? And then the last thing he talks about in this section is to make sure that you take your time. A lot of times when someone is diagnosed with something serious, you go through the 5 stages of grief. Of course, you first start in denial about that. You go through denial, you get mad about it, you bargain, you start to get depressed, eventually you're going to accept it. But in the denial stage, you may panic and think, oh my God, I've got to make a decision right now, and so you'll go with the first decision that you're presented with. Chemotherapy, radiation, let's go with this very aggressive form of treatment, or let's put you in the hospital and do surgery right now, we've got to do it today. Most cases, not all cases, but most cases are not an emergency right now. You do have time to think about your options. You have time to get another opinion. That's one thing he mentions in here. Get as many opinions as you need. Talk to your family. Research it. Find out what exactly your disease process means. A lot of times we as individuals forget that we don't have to do anything. It's up to us. We have all the power to say yes or no to a treatment. We can try it, and if it doesn't work, well, we don't have to keep trying it just because somebody thinks that we should. The second thing that he talks about in this article is giving yourself a break. And he says it's hard to be sick, and it's hard to be dealing with medical problems. It's even harder if you must be responsible for determining your own course of therapy. And this is probably a reason why most of us just want our doctors and our family to tell us what to do. I'm too overwhelmed by it. Just tell me what you want me to do. Being responsible for your care doesn't mean beating yourself up for your present condition. And your present condition is stressful. So encourage yourself a little bit. He believes that most people are way too hard on themselves about all sorts of health issues. Self-critical thinking is common, especially with lifestyle diseases. I'm weak, I have no willpower, I'm a failure, or I should have lost weight. I shouldn't have eaten this, or I shouldn't have done that. That's what gave me cancer, I should have stayed out of the sun. With other illnesses, people might think, I should be better than I am. I'm different. I'm really not handling this very well. Why can't I be upbeat like everyone else? And in reality, you probably aren't much different than everyone else. No one has it all together. You just don't know about anybody else's problems or feelings. He's heard this described as, the quote, we compare our insides with other people's outsides. And this is very universal and true. One thing that we recommend in this case scenario that's not in here, but is, and unfortunately there's not a whole lot of these around town, but support groups. If there's not one, you can request that one is started. You can request that from a local grief group, CAMRAD. You can request it from a local hospice. Say, I really think this is something that would be worthwhile, and maybe you can be a champion in that group. But there are also a lot of groups out there, renal support groups, cancer groups, diabetes groups. And these groups, although a lot of times we think we don't need those, we'll deal with it on our own, they can be tremendously helpful for you because you have the ability to go in and see that you're not the only one feeling the way that you are. Your family isn't the only one that feels that way. And maybe you can learn from each other. How did you get through this? Everybody's going through the same thing as you, so there's nothing to be ashamed of or embarrassed. He goes on to talk about medical professionals, and the research shows that they are no exception. Oftentimes we think that doctors and nurses and at the end of life must be so much stronger, they're educated, but really research shows that they're just the same as we are. So the same physicians who so confidently advise patients on their best options don't do any better when the roles are reversed and when they're patients themselves. That's somewhat comforting to me to know, because there's a human connection there. They get just as confused, depressed, and demoralized as anyone else, and they have just as much trouble making decisions. I've read many essays by doctors facing serious illnesses, and this is a universal theme. He continues to say that pretty much all of us are just doing the best that we can in life day by day. You are too, and it is okay to have problems. It's also okay to not deal with those problems well. Tell yourself that, accept yourself as you are, and focus on the next step. What is it that I choose to do for now? One of the things that you can do as a patient or as a person dealing with a serious illness, a family member, in addition to a support group, is to encourage your family members to reach out to local grief groups or caregiver support groups or respite groups. There's many that are put on by Missoula Senior Aging Services. I know Partners does them, Tamarack's, Hope Center, Hospice in Missoula, Aspen, Rocky Mountain. There's a lot of resources out there. A lot of times people bypass hospice because maybe you're not involved with hospice yet, but there's a lot of things that hospices provide to the community regardless of whether or not you're enrolled or you have somebody that's enrolled, or maybe you'll never have somebody enrolled. But you're always welcome to come to any of those groups that are available. They're confidential groups. That's probably your biggest resource here in this community. They're most often led by bereavement counselors or chaplains who can then also assist you one-on-one if you need that help afterwards. So that's a great resource to you, and just know
Now,
that.
is this just for patients or their family members as well and caregivers?
Patients, family members, and community members. So you don't have to have been a part of the hospice program. So they're open to anybody. I know right now, Missoula Aging Services has a caregiver support group that is going on. I believe it's the second Tuesday of every month. There's one going on at the library right now that's put on by us. There's one that happens at the village senior center every week.
And these are all for caregivers? Or
These are all for caregivers.
Okay, good.
And you're welcome to call, any of the other community partners and see what they have available for you. We do share all of our information with Tamarack Grief Resource Center. So if you needed, if you called them, I believe Partners does as well. There's a web of connections throughout the community to help you get you where you need to be. The third thing that he talks about is asking for help. He says if you're going to be responsible for your care, you probably can use some help. Most of us could, but we never ask. Why is that? More unhelpful thinking. I could never ask for help. I'd be too embarrassed. I don't want to be a burden. No one really wants to help, but they would feel obligated to help. Actually, people do want to help. He continues to ask each of you to think of a situation where maybe the roles were reversed, and you knew somebody that was sick, and the feeling that you had to help the person. Most of the time, you do want to help, but it is a human part of us that thinks, and this happens all the time. I don't know, Claire, you probably hear it all the time too. Patients don't want to ask for help. People don't want to ask because they are afraid that they're going to burden somebody. I don't want to be a burden. Or they already feel like they're a burden, so this is just going to push it over the edge. Go ahead.
I oftentimes think people are also in denial of the seriousness of their condition.
Right. And what I found is, especially here in the culture here. Go ahead, Amy.
No, I'm just saying they don't ask for help until it's too late sometimes.
We have a really strong culture in Montana of independence. And I've been really surprised with that culture because it's not that way in Utah where I come from. It's really interesting. I'm from Utah, and even though they're not that far away, it really seems like people in Utah jump to whatever we tell them to do. Just like I was talking about. You need help. Okay, give me some help. It's not that way here. You need help. No, I think I'm okay. I'm going to live by myself for a little while longer. I've done this. I'm a rancher. I'm a hardworking person. And it's not until you're in a crisis that the help is given to you, and it's not because you wanted it, it's because you get it. So, and then you're mad about it afterwards.
We have a question here.
Okay.
Going back to what you said about help. It's not always that you don't ask. I haven't talked to many neighbors, but he's made it quite clear he won't tolerate any questions that are not cancer cell related. And I find that I was intimidated to start, but then after I asked a couple questions, and there was his response, I don't ask him any questions.
Because of the response that he gave you.
Yeah, he's made it quite clear he's not interested in answering anything that's not cancer cell related.
Have you researched through the clinic to find out whether or not they have available to you a medical social worker?
Oh, the social worker is a very different story. The woman, highly energetic, she cares quite a bit. We talk about, I'm not afraid to ask her anything, but as far as telling her about the doctor, that's different. I haven't, because I'm glad to have a doctor, you know what I mean?
Right.
And I don't want to threaten that. I have no alternative.
I think that's a pretty common feeling though. And we were going to talk about that a little bit. The average doctor visit is about 7 minutes long. And this is because really how busy they are. They're back to back to back to back. So one of the things that I really recommend to you, especially with cancer treatment centers around here, is to get to know that social worker because they're an invaluable resource to you. And if you have a problem, if you don't feel like you're getting your answers from your doctor, well, that's what they're there for. They should be there to help you navigate that and to help you make sure that you do get those answers. So whether or not if it's not something that you can get during your time with the doctor, well, then tell them maybe next time I need a longer visit with you. It's scheduled, let's double book me in here because I've got some questions for you. And I think what's important to remember there is that you're the boss of your care. A lot of times we seemingly get bullied to not feel that way. But the doctor is hired by you to take care of you. So if you have questions, he needs to answer those for you. So being able to be an advocate for yourself, or if that's difficult, finding somebody that can advocate for you. So whether or not that's a social worker, a friend, a family member, to go with you to your doctor's offices, to your visits, if you have somebody like that. Write down your questions before you go and just say, we've got some questions that we need answered before we leave here today. So, and if you're still not getting results, then you need to talk to the social worker about that.
He is quite busy, like you said. There's some busy.
Right. So maybe that what they need to do, you know, and give them that, because we do know how busy they are. But when you make your next appointment with them, just say, can we schedule two blocks for me this time? Because they do schedule them pretty quickly. You know, they're scheduling back to back every 15 minutes or 20 minutes. And then, you know, they have an hour off or so for lunch. But if you know that you've got unanswered questions that you need to spend that extra time with them, ask them for that extra time. And they can give you that time. If they don't give you that time, then demand that time. Or help you, or find somebody that can help you demand that time.
Has to be an alternative to making a demand.
Well, it needs to be respectful, man. But you need to feel empowered to be able to take control of your care. So, and if you're, it sounds to me like you're not getting your answers to your questions, which means that you can't possibly understand what's going on with you, not fully.
Yeah, and if you don't, if it's a serious question, even the social worker and the nurses will defer that question to the doctor.
Right. Yeah, that's difficult. So do you have an advocate for yourself? Do you have somebody that can go with you and?
No. Yeah. Because it's like you said earlier, I think you know yourself.
Right.
I mean, hell, I know what I'm like. It changes over time with certain medication.
So this is your assignment for the rest of the night before we get done. Think about some people that might be able to be that person for you. And we'll talk about it again before the night's over. Okay. So a couple of questions or things that you should be able to ask for help. A couple of things that you should be able to ask for help for are help understanding your treatment options, help changing your lifestyle, help managing your emotions, helping with tasks and activities where those are required. There's a lot of resources that are out in the community. Some of them need to be paid for, some of them not. A lot of things that are untapped that people don't know about. And a social worker really can help you find those things. That's what they're supposed to be doing. So I want to talk a little bit about palliative care. And palliative care is not something that is widely available in Missoula right now, but hopefully it will be soon. And what the difference between palliative care and hospice care is. So hospice care is a modality of care that is intended to take over once treatment options are exhausted. You have a serious illness that's become terminal, and your doctor feels that you're in your last six months of life. So hospice is intended to come in and help you holistically, meaning mind, body, and spirit, help manage your symptoms, and prepare you and your family for the end of your life and leaving this planet. Palliative care, by definition, is treating a symptom, whether or not that symptom's physical or whether it's emotional, spiritual, and making it feel better, essentially. So when you give yourself a Tylenol, you're giving yourself palliative care. And palliative care really should be started at the onset of a disease. And this can be started by anybody. So even though there's not palliative care programs in Missoula yet, it's important for you to know what that means. So at onset of a family member's illness or at onset of an illness of your own, you can tell your doctor that palliative care for you is very important, even though you may experience some treatment options, whether you have cancer and you're going to undergo chemotherapy, or you're a renal failure patient and you are going to undergo dialysis. all of these things come with side effects, and a lot of times those side effects are negative. You know, most often, renal failure patients, cancer patients, heart failure patients are in and out of the hospital a lot in the last 2 years of their life for symptoms related to treatment or the disease. And those are things a lot of the times that we can manage, but they're undermanaged because either they're not reported or there's just not enough manpower to really follow those well. There is home care. Well, home care is bound by regulations for Medicare that state that you have to be one, homebound, and you have to have a skilled need. And if you don't have those two things, both have to be there, and you don't get to have home care. If you do get home care, once those two things go away, or one of those two things go away, then you get to be discharged from home care. So then there's this large gap between what am I going to do from home care, what am I going to, and I don't need hospice yet, but maybe I'm really sick and I'm in and out of the hospital a lot, or I have a lot of symptoms that need to be managed. It's hard for my mom to go to the doctor, you know, and her doctor doesn't come home to her. So palliative care, as we would like to see it come to Missoula, would be to take healthcare back to the home like it used to be. So a couple of things that you should know about palliative care is, where do you receive palliative care? And palliative care is provided in any setting. So like I said, it's really just managing those symptoms. So empowering yourself to tell your doctor, I'm going to do chemotherapy, but I don't want to be nauseous. And I know that there's medications out there that can treat that for me, so help me out with that. You know, help me out with that, or get me in touch with somebody that can help me with that. There's doctors, palliative care physicians, the hospices, they can give you information, they can come out and talk to you, even if you're not ready for it yet. Does your insurance pay for palliative care? So most insurance plans, including Medicare and Medicaid, cover palliative care in one form or another. So whether or not that means covering your physician to go see your mom or your dad, or the physician to go and see you because it's hard for you to get out of your home, that can happen. That doesn't mean that all of your physicians are going to do it. So this is something that hopefully in the future we'll be able to have this program widespread, where our palliative care physicians around the town can come to you rather than having you go to them and see you in your home. How do you get palliative care? At this point, you ask for it. You just need to let your doctors know that, yes, even though we're going to do curative care, I want to be comfortable. You know, I want to be treated like a person. And I don't want to have all the symptoms that are associated with the treatment that I'm going to undergo. How do I know if palliative care is right for me? So palliative care may be right for you if you suffer from pain, stress, or other symptoms due to serious illness. Serious illnesses may include cancer, cardiac disease, respiratory disease, kidney failure, Alzheimer's, HIV/AIDS, ALS, multiple sclerosis, or more. It can be provided at any stage of illness along with treatment meant to cure you. So that is the biggest difference between palliative care and hospice. With hospice, your treatment is stopped, but with palliative care, you get to continue on with treatment options, but you get to have that holistic care on the side. What can you expect from palliative care? You can expect relief from symptoms such as pain, shortness of breath, fatigue, constipation, nausea, loss of appetite, a whole wide variety of different negative symptoms that come along with the dying process. Who provides palliative care? Palliative care is provided by a team including palliative care doctors, nurses, and social workers. Sometimes massage therapists, pharmacists, nutritionists, and others might also be a part of these teams. And how does it work with your own doctor? Well, palliative care should always work as a consultation service, so we should work hand in hand with your physician. It doesn't mean you have to give up your primary care doctor, which is really important around here. So if you can get into a palliative care program, what they'll do is they'll work in conjunction with your physician to make sure that there's coordinated care. Make sure that we're not changing something, medication regimen or something of that sort, that your doctor's not in agreement with, and vice versa. You should be talking to the palliative care team to make sure that they're not changing something that they don't know about, so that we can make sure that we're staying on the same page. Anybody have any questions about that? I know that there's a pretty interesting program that I'm fairly excited about that they're putting together at the Cancer Center, a community medical center. It's a nurse navigation program for those patients. And it's not here yet, but it is on the horizon, so that is something to look forward to, where the nurse navigator can help those patients that have cancer work their way through the system from diagnosis through the end of their life or through cure.
What's the difference between a nurse navigator and a hospitalist?
A nurse navigator is somebody that will be assigned, so the hospitalists are in the hospital. They're following patients essentially through their admissions. Nurse navigators will be, ideally, they'll be attached to someone at the beginning of their treatment. And they'll help you figure out which treatment options are, do you understand what's going on, and follow you through to cure or to end of life.
In and out of the hospital, in other words.
Yeah.
In other words, they attach to you rather than you see them only when you're in the hospital.
Correct.
Which would be the hospitalist, okay.
And the hospitals are doctors,
Right.
they're physicians
Right.
rather than nurses.
Right.
Rather than nurses or nurse practitioners. Yeah.
But I just wondered what the difference in roles was.
Yeah. So your biggest, right now in Missoula, like I said, I did a search for healthcare advocates because there are a lot of advocates around the country. And unfortunately, there's not any in Missoula. So the nearest ones are in Spokane. However, a lot of them can help you via the telephone. So you can give them a call and tell them what you're experiencing, and maybe they can give you some tips. You're also always welcome to call us. Call any hospice around town. And just tell them what's going on. Do you need a consult? Do you need some bereavement services yourself? And even if you're not ready for hospice or palliative care when it's here, we're more than happy to come out and help you with that. There's a guide available to everybody. It came out in the newspaper. I put it up there on the desk, but it's particularly by the Missoulian called the Missoula County Health Guide. I believe that, I don't know if they have stacks of them anywhere other than the airport. That's the only place I've seen it.
The Chamber of
Maybe the
Commerce.
health department's coming into an airport.
Yeah. Oh, you know where to go.
Guide for the
It came out in the newspaper a little bit ago, but it's quite a extensive guide that's broken down in sections on different areas of healthcare. So it's kind of nice. You can open it right up to home health, or open it up to hospice, or open it up to chiropractic, and just see all these different but available resources in the community. Missoula Aging Services is another great resource for you. They do advocate for Missoula area seniors. And then, like I said, the medical social worker, if your physician's office has one, you really should get to know them so that they can help you. Social workers are intended to be there to help you navigate the community resources. If you don't have one through your doctor, then give one of the hospices a call and see if you can get hooked up with them, and find out about hospice, because sooner or later everybody's going to need it. But chances are, and I can't speak for the other ones around town, but I believe that they're all the same, that they'll help you.
You know what, I just want to, and I didn't know you were going to say such nice things about social workers, because no one really knows what they do, and we all have a perception of pushing paper and listening to problems and not really doing anything. Here's what I want to say is that find a social worker, hold them accountable to your goals. You said something about you needed to understand what your doctor was saying, or you have these questions. Give them that task. I need these questions answered, and I know you can help me. We're not just touchy-feely, we're not just pushing paper. We are helping you reach some goals that you need help with, particularly if you don't have family, advocacy around. And I would like to think that, if someone's in the hospital, you can ask your hospital social worker, you can ask a hospice social worker. We all, there's numerous, and Marika, maybe there's more, resources, the Cancer Center that have social workers, that's really our job.
You guys
is to
are
be
on some
advocates.
heroes. I used to have that attitude too years ago, that social workers, why are they needed? And man, I have come completely around. And just had some wonderful experience with social workers.
Hold them accountable.
They'd be my go-to
Yeah.
first day in the hospital.
I always say I'm your personal assistant.
Yeah,
This
really.
whole
I mean, almost like an
medical thing.
advocate, aren't you?
Yeah.
I mean, in a way.
Yeah, we are.
If you
We
can't
are.
find a personal advocate for yourself, like a family member or something.
The
social
social
worker
worker
is the
will
place
take
to
that
go.
on, and you need to, here's the hard part, you need to ask, but also set some really strict goals. Here's what I need to have happen, because we work for you. We want you to be successful in navigating your health care. And we like results as well, not just the process of it.
Yeah, I think that's, a lot of times, patients and family members don't understand why we assign a social worker to every single family. But by the time that the social worker's been there a few times, it's an invaluable resource to them. So there's somebody to vent to, but most importantly, to hold accountable. So almost every, and I say almost because I don't speak for every modality, but almost every modality of healthcare should have some sort of a discipline in place that is similar to a social worker. So most physician offices will have a social worker. Cancer centers have social workers, hospices have social workers. And then there's, Missoula Community Health, the county department, they have social workers and case managers. So you should be able to get yourself a social worker that can help you. So, and if you can do it, and just like Claire said, hold them accountable. Because they are the ones, there's a reason that the doctors want them there. So they don't have the time. They've got the whip, so they can help the doctors make sure that they stay in line.
Are you saying is it unreasonable or reasonable to have your social, especially if I don't know what happens, to come to the doctor with
I don't know how that's, I don't know what the HIPAA laws are, to be honest with you. He asked about social workers coming to the doctor's visits with you. And I have not been asked to do that. I've been asked to do that as a volunteer. I'm going to defer to Angie in terms of what the HIPAA regulations are. Here's what we can do. A, provide you with a list of questions that the doctor can answer and a tape recorder. I mean, we can do things, and I'm not really sure. I've never been asked to actually go to a doctor's appointment. I think you should ask the question no matter what and see if their agency feels comfortable with it. But you bet, and we'll take notes and we will speak for you, and you can also say your concerns to us prior to the meeting with your doctor, and we can kind of massage it. Yeah.
I agree with Marika though, if the patient wants the social worker to come and they're agreeable, that
I would do it.
that
in a heartbeat.
suffices,
I mean, I know for both oncology clinics, they have social workers that work inside the oncology clinic, and those social workers will go with you to be an advocate for what you want. So
Right.
that happens a lot. Yeah.
Yeah, HIPAA lies with you. So
Yeah.
really, the only barrier to a HIPAA violation is going to be you. So if you say that you want somebody to come with you, then the doctor office has to let them come with you.
Yeah.
So, most of the time I'll send a nurse with my patients. But if you don't have a nurse, if you're not enrolled in a program yet, absolutely you can take a social worker with you. So, or a family member, a good friend. A lot of us have that friend that's not afraid to speak their mind. And a lot of times that's the person that you want to have be your power of attorney, because you know that you're going to get what you want. So, and they can go with you too. There's a sheet that's put out by the National Hospice Palliative Care Organization that I put up there on the table too, but it talks about if you or somebody that you love is very ill, ask the tough questions. And they're going to make people uncomfortable to answer them. But you need to have these answers in order for you to decide what is best for you. I cannot tell you how many times somebody comes to hospice and they would have come much sooner if they would have known about it, or palliative care. And that's hard to say, because hospice to a lot of people means the loss of hope. But really, there's studies out there, and it's not the loss of hope, it's reorganization of your hope, really. So, and hospice is not something that is concrete either. So if you think hospice might be for me and you come on and it's not for you, then go off. It's okay. or if there's a new treatment that comes out, it's another example of how you're in control of your care. You can come on, come off anytime. So there are some regulations that are too dry to talk about right now, but for the most part you have that power, and the same with palliative care. Just because there's not a program here yet doesn't mean that you can't have it. You just need to force that issue with your care, with the people that are taking care of you, with your doctor.
Well, palliative care, I understand that it's, like you said, treating symptoms. Why is there such a, if there's no curative power from medication, why is there such an insistence of a regimen for a given medication so long a treatment? Why isn't there a consideration of aging care? For example, Chinese medication, do they have better results regarding stage 4 cancer?
You know, that's something that I don't really have statistics on, but that's one reason that it's important for you to know all of your options. Because like this article said, most of our docs are trained in Western medicine. So you may not even be offered non-traditional types of treatment. So find out about those, and if your doc doesn't know about them, then find out who does know. Another resource to you guys is 211. I don't know if anybody's ever used it before, but 211 is a resource that you can call, and it's a community resource guide. You can call them and you'll get an operator, and you can tell them what it is that you're looking for, and they will help you find something that's already in the database, or they will research it for you and call you back with some information. So on who you may be able to call to get more information.
What would be a yardstick of effective medication for palliative care? The odds, beside the feeling of the person, the only yardstick I've been given is the CEA.
Mm-hmm. So how would palliative care work? Is that what you mean?
Is there another yardstick for effective palliative care? I'm talking about the body. Is there another way to measure the effectiveness of the medication besides the CEA?
I don't know what the CEA is.
What is CEA?
Carcinoma,
Yeah, the
embryonic
Oh, it's the
antigen.
test that you're taking.
Well, how you feel.
How you feel.
Subjective, but it's how you feel.
Yeah, but if you're hoping to stay alive for as long as you can, is there another measuring device besides the CEA that can tell you how effective this medication is? Because there's a price of a side effect, but you want to be able to measure, is it cost effective? What are the benefits of this medication?
The CEA is probably going to be your easiest and most cost-effective way to test that. But there are many scans that your doctors can do, whether or not you've had them, PET scans, x-rays, depending on what the answer is. The thing there is to question, and you don't want to do them too often, but you know, why are you having the scan done? So if you're treating it, then obviously we're seeing if it's working or not. So, and then making sure that your doctor is just straightforward with you. You know, a lot of physicians are very scared to be straightforward with people. Physicians are trained to heal and cure people. It was interesting, about 2 weeks ago we had a grief conference up at the UC Center, and Dr. Peterson Hale from CMC came and spoke, and she said not once in her medical program did they talk about the fact that 100% of people die. Not once. It was all about how we're going to fix everybody and cure them and keep them alive. And we have done that, and effectively what we've done, in addition to that, is lengthen illness and unfortunately suffering that goes along with that. But that comes to show me that even the best physician out there that may feel a sense of failure to a patient who they have to tell this isn't working anymore.
So did anyone see or go to Ira when he spoke here most recently? Just a couple, I want to say it was 2 years ago.
Yeah.
I did.
Yeah.
And when he had mentioned that, you know, the real issue with new doctors is that it has to start at their training level, because, you know, when they're getting trained in medical school, they may have maybe three months of like gynecology if they're going to be just a regular internist, but they get maybe 1 day of end-of-life care. And really, they need a whole section of that, because what kind of population are they going to be taking care of? And they don't get any of that training. So the real push in the country has to be at medical schools, that we have to start training our upcoming physicians on end of life so that they start doing this. We train them, so it, you know, that's where the whole big picture has to start, and I don't even know if that's really occurring much now.
I was just at a conference where one of the physicians said, "We're Americans. We think end of life is optional." Like, that's very true. There you go. That's sort of our culture. Where we think, maybe not me. I could probably scale past that one. So.
I think that there's an interesting social dynamic going on in that people my age had 1 or 2 kids instead of 4 and 5, and as we age, there will be fewer people there to help us with these choices and to care for us as we age, compared to the generation that I'm in.
True. Yeah. Josh, I'm really happy that you brought up just the human side of physicians, and you know, it not only rests with them. You know, there are no physicians in this room tonight that I know of. There are human beings, community members, healthcare professionals, lay people, but it's our responsibility too to start talking about death early with our families, with our children, so that we can deal with the sad transitions, not only the joyful transitions that come to us through life. And then when we know that we have a serious illness, to give physicians permission to be honest with us. Because routinely what we do is appear on their doorstep and say, fix it at all costs. And that puts a tremendous amount of responsibility on someone who isn't God. But they have been allocated that responsibility, and so they keep on trying and they keep on trying until a patient generally will say, you know, I think I'm done. I think I can't do this anymore. And that perhaps will allow a physician to be honest and to say, I can support that decision. The other thing behind physicians, specifically in the oncologic area, is that almost every oncologic clinic has a research-based physician. So they have a researcher there. They've written grants, they have medications and chemicals and new ways of treating things, and they're always looking for ways to utilize those, because what they want is success. They want to provide people with cures and comfort and longevity. And so you know, that physician has this consult behind him saying, what about this? What about this? And it's important for us to recognize that there's somebody else on the team, not just that doctor thinking about what's the next treatment that could come down the pipe. And that person may not even know you. They just know your case, they know the drugs you've had, they know the kind of cancer you have, so they don't know anything about your goals. And if you're not expressly telling physicians what your goals are, he's got this other person on his team that's saying, I think we can do better with this drug, or this medication, or this next regime, not ever having known what your goal really is. And I say that based on when I get to meet families, one of the very first questions we ask them when we go out to the home the first time is, how can we help you do what you want to do? How can we help you spend this time that you have left, no matter what it is, whether it's 3 months or 6 months or a year, doing what you want to do? And that's what we aim for. That's what we go for. So, so it's important that we stress what our goals are when we go as patients. And we take some of that responsibility on ourselves.
And totally dovetailing and adding to that is what you said earlier is we're the consumers. The doctors work for us. What do we want? What are we, the supply demand, the marketplace, if you will, is the business of medicine. We are the consumers and the ones paying for it, so we should ask for what we want.
But the biggest barrier there
And that relationship of dominant doctor, submissive patient, okay, what do you think, versus team, togetherness, and asking for what we want versus being told what we're supposed to want.
I think the biggest barrier though is that most of us don't know what we can want.
Exactly.
No, we don't. We know that, and we use cancer a lot because it's the easiest to relate to, but we know we have cancer and we know that the doctor wants us to do chemotherapy, but did we ask them what happens if I don't do anything? Or what happens if I change my diet? You know, my grandfather lived a couple of years longer than they expected him to because he did a pH diet and it worked. I mean, and I'd never heard of it before. But he did bladder washes and changed his diet and ate nuts and all these other things, and the cancer went into remission. And he didn't do chemo or radiation until that very, very end, and it didn't work. And so he decided that I'm going to live my life. So he did what most people don't do in finding out what his other options are. So, or asking, you know, how many times do we see that the oncologist told the patient, I can maybe get you 2 more years with chemotherapy, but they didn't know that 2 years was going to be riddled with hospital visits and being with your head in the toilet and weighing 90 pounds and just sicker than a dog and not able to have any energy to be with your family. Where maybe without chemotherapy they could have lived 1.5 years, but it would have been a good time.
Well, Josh, just to be a little bit of a devil's advocate here, is the doctors presenting you with what they know based on studies that they know that this has been studied, that with this treatment we can give you this much. They can't tell with any certainty to a patient, if you do nothing, you're going to have this long or you're going to have this long. And so that's what's unsettling to a doctor, is he has some evidence behind, I can tell you this, but he can't tell you what's going to happen if you don't do anything. And I think that's
right.
You know,
And the other thing that's come up for me, and because of, you know, just all of your comments, is, you know, it's the difference between cure and curiosity. And I'm not going to take credit for that little statement. I heard it from someone else. But it is not about cure at all costs. It's about curiosity about what's going to work for you in your life.
Right.
And, you know, you want to approach it that way. You want your social worker to approach it that way. You want your doc to at least know that that's where you're coming from. Because that's really what we're all coming from. It's like an unknown. So we're really curious, how's this going to look for me? Not, I want to be cured at all costs. And I think that is something we all need to think about, and I've thought about for my patients, for sure.
And how do you want it to look for you?
Yeah.
So, I mean, if you want everything,
right,
to keep me alive.
Be curious
Absolutely.
about that and say, I want the cure.
Yeah, then let's do it. Tell me what I need to do and what to expect. So, but I think that empowerment piece is what we need. So I think we need to be empowered to finally, to be educated. We need to educate ourselves. Be empowered to take control over healthcare.
Part of the educational system also should include how to pick your healthcare providers. Part of the, I mean, I remember as a kid going to the doctor and you'd wait about an hour and then he'd come sweeping in his white coat and, well, in my case it was a he. He'd come sweeping in his white coat and, geez, he was like a priest at confession, you know. Okay, you're out the door, and I never knew what was going on. So as I got older, when I first came to Missoula and I needed a physician, I had a physician here for a while, and the same thing. And I really felt like I'm an adult now. I think at a certain point you should be able to talk to me about some of these things and let me know what's going on, because I'm gonna have to make some calls on my own well-being. And I finally found a doctor who would take the time to explain things to me, and it really made a huge difference. And then he ran off with some gal in Hawaii, but that's a whole other story.
He was a very good doctor, though.
I went into St. Pat's Library just 2 days ago asking how in the world can I find the best neurosurgeon in St. Louis? And Dana said, I don't know. She said, you can go online, all those places. You have no idea the people that are blogging and whether they're even sane.
Right.
Those are not good measures of who the best doctors are. But then I found something called America's Top Doctors or America's Best Doctors. And I didn't go a whole lot further with it because I found Barnes Hospital, and they've got so many America's Top Doctors, it's like fleas on the back of a dog. So I thought, well, I'll send my sister there. It's a teaching hospital. But, you know, when you are faced with a life-threatening illness, suddenly you want the best you can find. You don't want to get channeled to the person who has the quickest, most available slot to put you in to operate on your brain. You want to know that this stranger who you're entrusting your life to can be trusted to know his stuff, and it's very, very difficult. And that's one of the very first places that I think we feel powerless as consumers. You might get a recommendation from your doctor who hasn't always done the best for you in the past, so does he really know what he's doing, or she? And you get a different recommendation over here, so you're getting names, but are these really good? And you need a timely decision, and it's a crapshoot. Really, pardon my French, it's very, very intimidating to walk into a stranger's room facing neurosurgery, and you gotta have it now. So how do you go about, does anybody here know how you go about getting to a place of comfort really quickly with that question? Social workers, maybe, I don't know. Are you guys truth tellers when it comes to who's good at social workers too?
Yeah, I mean, my sister's a doctor, and she's in Seattle, and they have this doctor's code that, you know, no one's gonna say anything about another doctor.
No.
Yeah. So I'm not saying social workers are the answer. I think the answer is looking at teaching hospitals and those kinds of things, and doing this, talking to as many people as you can. And it is just that. It is just managing that. And whoever is at the end of the day, the person you choose is the right person you've chosen.
Well, did they treat you like a person when you talked to them?
Yeah.
Did they come in and actually make eye contact with you or your sister? And did they want to spend the time to get to know you? And how did you feel?
Although surgeons never want to do
No,
that.
we're not about
That's
surgeons.
true.
Let's not talk about surgeons.
Asking for 3 references.
You know, we live in such a litigious society that when people are afraid to say something bad about somebody for fear of somebody suing them. I mean, it's the same thing. I used to hear calls all the time, job references on people. And I would say, they worked for me from such and such a date to such and such a date. Would I hire them again? It depends on if they came and applied, which is a total non-answer. But I mean, you really couldn't say, because we were told by attorneys that, you know, if you step up and you put yourself out there, don't be surprised if somebody sues you if they don't like what they hear.
Yeah. That's unfortunate.
Ever since coming to Missoula in '86, I started a running blacklist, whitelist of medical people. It's the best way I can think of, because I can't remember names over time. And so, you know, that's my go-to list occasionally for myself and friends. As a way of at least weeding out who you don't want to spend time interviewing with.
Right. Most of the time you can search online. There's best grades and some different websites that have the doctor's information, so you can get on there and see how long have they been a doctor, what is their experience, and if those things aren't available online, then ask, you know, how long have you been doing this for? Because if you have a neurosurgeon that's only been a neurosurgeon for a couple of years, then maybe you
don't want him messing around with
Yeah, or maybe you do want him instead of the one that's been a neurosurgeon for 20 years.
Or the one that has the certificate of medicine from the University of Grenada.
Yeah, right. Yeah.
Right. So the research is important if you have time to do it. So there's a couple of websites that I wanted to share with you guys. The first is advoconnection.com. It's advoconnection.com, and it's an alliance of professional health advocates. And like I said, I did a search on our zip code here, and there's one lady named Amy Simmons who's in the Washington area. The rest of them are farther away, but a lot of them may be able to help you via the telephone. They are healthcare advocates. And then for cancer-related issues, survivorship.a2z.org. I just found this website about a week ago, but it was developed by a gentleman who had a really hard time navigating the healthcare system himself with a family member, and so he's developed this resource. It's divided between different cancers, but it's just stocked full of a ton of different information you might need.
What was that one, Josh?
It's survivorship.a2z.org.
Two, the number 2.
No, T-O.
Okay.
And it's full of things, you know, like how to take care of your finances, how to decide on advanced directives. I mean, there's so much on there that I wasn't able to even look at part of it. But it seemed like a lot of great information, so.
For those of you who are in the field of healthcare, you're aware that Missoula was the National Center for the Promoting Excellence in End-of-Life Care Project of the Robert Wood Johnson Foundation years ago, and they have completely archived all of the data from that grant project, which was a huge project around the country, and this was the epicenter of it. And I don't know where to go online for that, but one of the, but you can find it just by putting in promoting excellence in end-of-life care and come up with the archive. And one of the important things they found out toward the end of their work was that palliative care applied in ICUs, or in trauma centers rather, also in ICUs, palliative care lowered costs and made patients and their families happier. It was like win-win.
And
that
providers.
was startling.
Right.
And the hospital administration started looking at that with sort of a sense of, oh, this was the first time that had ever come to light.
Right.
So it surprises me that Missoula doesn't have palliative care at its hospitals yet. To hear you say that.
Well, they're starting. And I will tell you that Care at Home is our palliative care program, and it is in pilot right now. We're seeing 5 people. It will be four-tiered. So this program will be home-based, following patients home, similar to hospice. It will be ER consults, so going into the emergency room and consulting with individuals who have been there before and may not want to be readmitted. They just need somebody to go spend some time with them and give them their options. We will be in the ICU. That is a pilot program that is in conjunction right now with CMC, Community Medical Center. So the ability to go and take the time to sit with families and patients in the ICU and decide what would mom want, you know, what are we doing, what can we do from here? And then also in conjunction with the cancer centers to help with those patients to make sure that they're comfortable. So it is in pilot. I'm not sure how long it will be before it's able to go community-wide, hopefully soon.
Very cool.
And that was exciting.
Is there a contact number for, is there a group in the evening for cancer support?
Mm-hmm.
There is.
Yeah, there are 3 that I know of.
I called the national hotline, I couldn't get it, but I'd like to get that for you.
Yeah, do you want to leave your number and we'll look them up and get in touch with you and give them to you?
Okay.
So is that okay? You don't have to tell it to me now, just if you want to write it down or?
Yeah.
Or if you've signed in on the sheet.
Did you put your number down on there?
No, I just came straight in.
There's a sign-in sheet there, and if you just put a little note next to your name, we'll know it's you, and then we can make sure that Josh can look that up or somebody else in our
We'll get it to you.
I just want to say that we're always looking for hospice volunteers.
Yeah. Yeah, that was a sales pitch.
what kind of things does the volunteer have to do?
The thing is, you could do anything. That's why
get to do.
hospice volunteers are so awesome.
Very
So
true.
you can work one-on-one with a patient, you could just do yard work for somebody, you can work in the office, like anything you can imagine to help someone out at the end of their life, you could definitely do it. And I know you have mad skills, I can just tell.
From
It
shoveling
would be great.
sidewalks to shoveling food into the mouth, however you want to do it, it
Yeah.
doesn't matter.
I mean, I think that that's the whole idea. I mean, for me, volunteering for hospice gives you the experience, so you understand what it's like to give that care. Then when it's your time to get that care, it doesn't seem so awkward because you understand how good it feels to give it. And I think that that's part of our culture, especially in Montana, you know, where it's like can-do people and like we don't need any help, but we do like helping other people. And if you've experienced that for someone on hospice, it's not so weird to accept that. You know, you really understand what that's like. So I say yes, all of you should be hospice volunteers.
Definitely you too.
We have a place. It's a really, really unique experience.
My mother helped start the hospice in Logan, Utah.
Oh, wow.
Oh, really?
Yeah.
Yeah, there's a bunch of them down there, but,
Yeah.
yeah. Well, do you know which one it is?
Cool. Well, it got absorbed by the hospital. They did just a good job, the hospital looked at it,
The
so
hospital.
we want this.
Yeah.
So they took it under their wing.
A lot of the hospices are getting gobbled up. So there's a lot of changes going on in Medicare right now. So the bigger hospices are buying them up and the hospitals are absorbing them, so.
But at least they got it started.
Yeah.
So that was a huge step forward.
So I would just encourage everybody to talk about palliative care and talk to your insurance providers and see if they cover it and if they even know about it. It's something that we're working on now. You know, I think that in 5 years, it'll be similar to hospice and that the insurance providers will see that this is very valuable. I mean, the archives that you talk about and the new studies that they're doing show tremendous cost savings for palliative care, and there's just a huge difference in the way that patients and families report how they feel. They're treated like humans. These teams have the time to go and spend with these people and to treat them like they're a person with a disease, not a disease. And so I think that we'll be seeing a lot more of this.
I also think that hospitals that don't buy up hospices and allow them to maintain on their own at a certain point with all of the financial woes that you hear about hospitals having, that they will be looking to deflect patients toward hospice more and more readily because it'll be less expensive all the way around for including the hospital.
Right. A lot of people don't realize that we can do almost everything in a patient's home, in your home, that they can do for you in the emergency room that isn't curative in nature. So, and to kind of put it into perspective, about less than a week's worth of time in an ICU is more expensive than a full month of hospice care.
Right.
So, I mean, that's pretty amazing. I believe it's about 4 days in an ICU with minimal care in the ICU is equivalent to a full month of hospice care.
And we'd all rather be home anyway, wouldn't we?
Yes.
Most people.
If we're at the end of our
I'd
life.
say it's more like 1 day in the hospital, 4 days just in the hospital.
Probably.
With not getting any interventions is a month of hospice care.
I would say that's statistics that we're running off of there, but probably true nowadays because those stats are kind of old. But most people, I think that's an 80-20 dilemma. About 80% of people want to die at home, but only about 20% of them do.
That's right. You're right. I remember that too.
But they've done some studies, you know, they've done studies where people with the same diagnosis, and it's cancer, but they received palliative care, they lived longer, their quality of life was better than people who received some sort of treatment and didn't get that at all. So they gave them the same treatment, but then supported these people with palliative care. And like everything was better. So it's amazing that that hasn't come full circle yet to be something that will provide people.
And less costly.
Right, save money, you know, your length of life was longer and your quality of life was better. I mean, that sounds like where I want to go.
Right.
Yeah.
But wouldn't you much rather be able to just call a phone number, get a nurse on the other line at 2 o'clock in the morning when you're in crisis or when your mom and dad are, instead of loading them into the car, calling the ambulance to go and take them to the emergency room? Which granted, with palliative care, you'll still have all the right in the world to do. But maybe we can send a nurse out there to take a look at you and say, it's okay, it's a panic attack, or let's give you some medicine and you're going to be better. Be much more control.
I listened to a kind of a neat thing on National Public Radio today. It was about a 5 or 10 minute little talk, and it was about a program that's going on in the state of Pennsylvania whereby those people who have been in the emergency rooms 3, and more times in a month are assigned a nurse to visit the home. And so they were talking to this gentleman, and he said, yeah, he says, it's really great. He says, I feel safe. And what the nurse said was that when she goes in and sees him once a week, takes a look at his medications, takes a look at his symptoms, asks him if he's had to take his nitro for his heart pain, those kinds of things, and making sure he doesn't run out of his medications, which patients so often do, so that symptoms crop up. And he was able to engage with her in conversations about his blood sugar that he never would have before. So he was more involved in his health care. He cared more about doing what he needed to do to feel good, all in the home. And so crises were prevented, and I think that's the big thing. Nobody wants to be in a crisis situation. Nobody wants that kind of panic over their health care. So if we can get there before there's a crisis, prevent those exasperating situations, not only for the patient, but his family, and then the institution that he ultimately gets to, too, because, they feel helpless, too. See, time and time again, they fix somebody and they go out and they're back the next week. And it's just a small amount of help.
So are those nurses coming out of the hospital to go into those
they're coming
homes?
out of community. They're coming out of public health systems, palliative care systems, insurance systems. Insurance carriers are getting really smart. They're hiring nurses to go out and avoid costs for them.
Right.
Yeah, you bet.
The palliative care nurses that I know from other cities say that there's no true med reconciliation unless it's done at home. Because you really don't know what someone is taking until you look in their cabinet and say, oh, what about that one? What about that? Yeah.
What's in that bag?
Right. And you don't really report that to your physician because you forget, or you think, oh, maybe sometimes I do that. It's just a different thing.
I had a referral just a short while ago for a woman with congestive heart failure who had been in and out of the hospital, the emergency room, multiple times. And so she'd come in, congestive heart failure, hypertensive, very hypertensive, full of fluid, and just having chest pain, shortness of breath. They'd fix her, send her home, then she'd come back again, and they'd help her, send her home, come back again. We'll come to find out that she hadn't filled her medicine for about 4 months and hadn't been taking it. She didn't have anybody at home to help her. So a simple solution, a fix like that, will keep her out of the hospital. So by being able to have someone there to help navigate that for her and help oversee that when she had nobody was, that simple of a solution, but look how many times it took her going into the emergency department before that was finally discovered.
Showtime has a series out called Time of Curiosity.
It is kind of nice because it shows you the steps that those people are going through to get the answers that they need.
Have you seen it?
I have, just the first episode. So it does, the first episode was pretty good. Of course it's dramatized a little bit.
Of course.
Like they are, but.
It's on TV.
Keep you watching.
But that's the best place to make a cultural change. I feel like we're sort of prone to see what happens on TV and then implement that into our lives. So I think that's good. I'm glad that we're talking about it.
Yeah. I wish that they put it on TLC or something that more people had access to.
Yeah.
They could put it on right after House Wars or Storage Wars.
Quarters.
Duck
Garbage
Dynasty,
Wars.
that's a little up. Yeah. Instead of Duck Dynasty this week, I'm watching All right.
So what's the next program going to be in January of the school?
December.
December's actually canceled. We're not going to do December. We're going to just move right to January. Yeah.
But there's
No December. That'll be our Christmas party. What?
Well, Josh, you've done a wonderful job here, and I really appreciate all the information you've given us. And
Thank you.
yeah, it's very helpful, and take a lot back with me to share with other people and help others. So I appreciate everything you did to put this together.
Thanks. Just to go back to our core topic, just remember, educate yourselves. Find somebody in your healthcare system or your family, find a friend, find that social worker, and get them on your healthcare, plan of care board from the beginning. Have somebody there that knows what you've gone through. So no matter what it is, or what your parents have gone through, or whoever it is that you're helping with, find that one person, because there is somebody there, whether it's a nurse or a social worker, or a nurse or social worker at the local hospice or health department that can help you. So, and hopefully in the future we'll have these new navigation systems, palliative care, and it'll make things even better for us. But if you have questions in the meantime, you're welcome to call anytime. I know that Partners is open for phone calls. We will take them anytime. So, and we'll have somebody help you.
I'm bringing my 91-year-old mother to live with me in Washington. And this has really helped me reconnect with some of the resources that I need to know about as being available to me. So I'm glad I came.
Thank you.
First thing I have to do is figure out how to renovate my bathroom to make it handicap accessible.
Not a small task.
After that, it'll be smooth sailing. Oh, God.
You can consult an occupational therapist. They can give you a lot of good tips. Because a lot of times people go above and beyond what they need to do. There's some pretty nifty tips and tricks out there that you can do to keep it costly.
Cost down.
The University of Montana has their gerontology group. So there's students and faculty at the University of Montana that help with things like that specifically. So they have occupational therapists on board, and then other people in the community that will help with resources.
Oh.
It's a really neat program.
So I should call where?
So the gerontology program at the University of Montana. So if you call, I think, what's it, 243 or 111, maybe. I think that they'll just direct you right to that. Yeah, as well.
411.
Yeah.
Okay, great. For OTs and
They have occupational therapists. They have people who are specializing in that in the healthcare profession. So they'll have, nurses and social workers and physicians that are in that loop, and they can help refer you out to those providers that you need.
great.
Yeah, they were going to have the senior prom this year, but it got canceled. But it was for senior citizens. Yeah, it's really neat.
Sorry,
Yeah, they didn't have a high attendance. We have to rally people up for next year. Yeah.
Well, normally, before we wrap up, we go around and ask everybody what they took away from tonight. So we'll start with you, if that's okay.
I'd like it to be one thing that you'll tell other people about tonight.
Oh, there we go.
Yeah.
One thing.
Yeah. You can say more. We don't mind praise at all.
Just the resources that are available, if you have somebody or you yourself are facing a terminal illness.
Perfect.
I think for me, the whole idea of taking control of my care and really looking at options beyond just, I think about the whole cancer treatment options beyond chemotherapy to mitigate pain, and I think that's a good reminder.
The first thing I want to say is that I'm blessed. I've been lucky. And in the path that I've found. Second, that hospice is a resource. Available as a resource. I thought you guys were just only show up when you're officially declared 6 months.
Just going to take back some of the different resources that you mentioned to share with other staff to just help them, navigate the system and different things they can use.
I think there's an incredible number of people out there that are not emotionally or intellectually prepared to deal with not only their own illness, but the illness of their families. And I think the more that the word gets out about educating about hospice and about other choices, the better off everyone will be. I also wanted to pass on you gave a couple of great statistics. Marika, what's the great statistic? You remember?
78% of statistics are made up on the spot. Right?
I usually go with 73.4 or something.
Only 99% of mine hold up.
My takeaway is I'm very, very comforted by the knowledge that so many people in this room are there for me and my parents.
Well, gosh, I think that more than one time I've left this room with this thought, and it's this, that we still have so much work to do. When somebody can speak in a group and let us know that we have physicians who can't address patients' needs, we've all got to work on that. Any way we can. Open up those doors, open up those conversations, and yeah, that's it for me tonight.
I think the value of a group like this is letting us know that we're not alone, and then it gives permission for us to become our own advocates and advocates for others. I came here after having years and years of informal health advocacy, and I got reams and reams of papers that support that and tell me what to do in various cases for family members. But I'm always looking to add to it, and I got to add to it tonight, and that's really cool. I have been a patient advocate numerous times, and I can tell you that if you can do that for a family member or a friend or even a stranger, it is so invigorating. It's almost like a reason to live. You're helping another person in a time of crisis. And the more we can advocate for ourselves and for other people, I think it just enriches our own lives.
What was the topic for January? Do you remember?
I believe that January is Yupa Stein, so she does arts and end-of-life healing. So she'll be here presenting about what they do in the community and how they help people at that time of life. So it's like art therapy. Yeah, she's amazing. She's been in Missoula for a long time, so it'll be really neat to learn more about that. Yeah. I always take the same thing from these conversations where I'm really, really glad to do what I do. Like, I really love working in hospice and palliative care because I see such a need. And what I want to do the very most is encourage other people to talk about it, because I feel like our voices are muffled sort of by the healthcare system. And not that it's not good, because it is good and it provides, you know, a lot of wonderful things, but it is sort of like the medical meat grinder where once you get caught in that, you know, it's hard to understand what do I want for myself. So I like these conversations because it reminds me not only to do that for myself and my family, but to talk to other people about their rights to do that for themselves. So being a healthcare advocate is wonderful, you know, and I want us to use our voices.
I didn't want to get into it, but once I did, it just opened things up.
Yeah, it's such a neat thing. And once you start doing that, you see how these can part for you. Physicians and providers want to do that. It isn't that they aren't willing to or that they don't want to, but they need direction too. They need to know what you want, and they can't provide you with what you want unless you say what it is.
Marketplace demand.
Right. And I feel that way for myself. You know, I think about obviously a lot about what I'm going to die from. I always think, okay, here are the symptoms I could live with, you know, especially raising kids. I don't really want to be tired. I could do with a little nausea, but I want to make sure I have energy. Like, what could you give me then that will cure my illness, that would give me these symptoms I could manage? Because I know what I want, but it's only because I've had a lot of thought put into it. You know, so think about that and encourage people to think about what they want. It'll be different for everyone. What about you?
I think that the conversation went great, and Josh was very nervous, and I think you did a fabulous job.
We couldn't even tell.
And I like the way that it went. It wasn't more of you just telling everybody what was what. There was intermingled conversation and questions during the presentation that went very
Great. What are you going to take away?
I'm going to take away that I actually know more about palliative care than I knew before, for sure. I mean, I was kind of like, I know we worked there and everything, but...
Oh, don't be embarrassed. I learn something new every time we talk about
about it.
But, I mean, I'm still like struggling with the differences of it, and I'm glad to see the more definitive boundaries about the two.
Mhm.
Okay.
That's great.
Yeah, I want to go back and say something about advocation. Another benefit of it, I have a friend who I was recently diagnosed with cancer, and I called him when his big appointment was coming and said, do you need somebody to go with you and make sure your questions get answered? You're going to be in a highly charged emotional state, and I'd be more than willing to sit and listen and take notes and give you answers afterwards. And regardless of the fact that he actually chose his sister to do that, which was fine, from my end, I just had made the offer, but it certainly tightened the bond between two friends, because he really knows that I do have his back and that I would do whatever it took that he needed. And I think that that is a huge thing for anybody that's going through a time like that.
That's awesome. Well, I just want to, I'll close with reminding people about the continuum of life. You know, we go through maintenance of healthcare to curing a disease, to curing and being comfortable and preparing to die. That I really truly think that education is our biggest friend, really. We need to educate ourselves. So there's one other video that's really quick before we'll adjourn. And I just, we talked about these last month, but advanced directives are a really great way to start the conversation about what do I want, you know, or what does mom want, or what does dad want. And there's a bunch of different ones out there. This is Montana's specifically. It's quite long. There's much shorter ones that you can use. But it goes through some very tough things that you need to talk about. And I think talking about those can really help you decide which path that you're going to take in healthcare.
I mean, Thanksgiving's coming up. Do that over dinner.
Yeah.
Everyone will be around.
Christmas breakfast.
That's right.
Christmas breakfast. Let's talk about advanced directives. So, Kurt, if you play that other video, then. Talked about the elephant in the room.
Oh, nice.
It was hard to see the top piece, but there's Ira right there.
Ira, yeah. Aw.
So thank you everybody for coming.
Thank you. So make sure that you sign in on the sheet here if you'd like information emailed to you so that you know about the next conversations and what the topics are. And when you want to volunteer, you can just give us a call. I'm always recruiting. It's